Good morning, everybody. It's a little bit after 8 o'clock, so I think we should get started. Looking forward to a really great session this morning. I'm Tim Donahue from UCLA.
And my name is Julia Meierle. I'm from Munich, and I think it's pretty early this morning, but we have a number of really wonderful abstracts, and with these hybrid format, we might really definitely be on time. And there's another question from our side, and that is whether Jason Pthl is already in the room, because he needs to hand in his presentation to the nice people in the back helping us with the technical questions. So if you see him, just send him there. And apart from that, I guess we should start.
Wonderful. The first talk is from Gregor Werba from NYU. The title is The Double-Edged Sword of Chemotherapy, Single-Cell RNA Sequencing of Human PDA Reveals T-Cell Activation with Simultaneous Priming of Inhibitory Macrophages. Gregor.
See, there you go. Well, good morning, everybody. Let me take the mask off. Thank you very much for the opportunity to present our work here today. My talk is entitled Dissection of Human Pancreatic Cancer Using Single-Cell RNA Sequencing. So as all of you are well aware, the human pancreatic tumor microenvironment is a profoundly complex and profoundly heterogeneous conglomerate of various cell types, all of which work together to erect multiple barriers to effective chemo as well as immunotherapy. And to really study pancreatic cancer, I think we need methodology that captures that complexity and that heterogeneity. So given that we employed single-cell RNA sequencing and prospectively collected tissue from pancreatic cancer patients and enrolled both primary as well as metastatic patients. We included naive as well as chemotherapy-treated patients, and then subjected their tissue samples to single-cell RNA sequencing using the 10x genomics platform. In addition to that, we employed strict quality control measures, both on the specimen procurement side as well as on the back end, the bioinformatics side. And as an additional layer of information, we incorporated clinical panels of germline and tumor DNA sequencing to generate this transcriptomic cell atlas of pancreatic cancer. In terms of our patient cohort, you can see the split up here. We have 9 resectable patients enrolled, 4 patients with borderline resectable or locally advanced disease, as well as 14 metastatic patients. Procurement was either by endoscopic biopsy, liver biopsy, or by resection. And of the 27 patients that I'll be presenting on today, we have 7 patients that received standard chemotherapy regimens, either with FOLFIRINOX or gemabraxane. So the landscape of pancreatic cancer and the pancreatic cancer TME you see laid out here. From those 27 patients, we were able to recover about 140,000 high-quality cells. And by dimensionality reduction algorithm, we used UMAP, laid them out here on the slide. And you can see that single-cell RNA sequencing really captures the majority and the major components of the pancreatic TME. Just to point out a few, you can see in blue the tumor cells right below the cancer-associated macrophages. In the top right corner, you see cells of the myeloid lineage, and in the bottom right corner, cells of the lymphoid lineage. And here are just a few canonical markers we use to identify those cell clusters. So with this cell atlas at hand now, we ask ourselves several key questions. Number one, how does the epithelial compartment, namely basal or classical differentiation, really shape the pancreatic TME? And then secondly, how does chemotherapy affect the tumor microenvironment, and how does it shape the TME? And then lastly, what are the clinically relevant consequences of changes within the TME, meaning what changes can we detect in patients with a good response to chemotherapy and those without a good response? And for purposes of this talk, I focused on one of our preliminary analysis comparing the effect of chemotherapy on the pancreatic TME. First, we took a deeper dive into, or a superficial dive, actually, I should say, in CD4 in the CD4 T helper cell compartment, and used differential gene expression to see what genes are upregulated or downregulated with chemotherapy. And what you can see here are violin plots that represent IL-7 receptor, CD69, CD44, as well as ICOS, all of which are upregulated in the CD4 helper cell population, suggesting that those T cells received some sort of an activation stimulus. And if you'd like to infer from IL-7, CD69, CD44, you could hypothesize that these T cells actually encountered an antigen. Similarly, looking at the CD8 cytotoxic T cell compartment, we again see IL-7 receptor, CD69, and CD44 as some of the markers that are upregulated. To a lesser extent, we also see inflammatory cytokine, or interferon gamma as an inflammatory cytokine that's upregulated slightly. And we also see a slight upregulation of CXCR4, a homing receptor. Interestingly, TIGIT, an immune checkpoint receptor, was quite starkly downregulated with chemotherapy. Next, continuing on to the tumor-associated macrophages, the first two markers used to represent here are HIF-1 alpha and VEGF alpha, both of which are upregulated with chemotherapy, suggesting that those macrophages embark somewhat of a tissue repair hypoxia pathway. In contrast to that, those macrophages downregulate IL-1 beta, CXCL2, 3, and 8, collectively suggesting that they downregulate the inflammatory machinery. Interestingly, in some of the genes that were differentially expressed in this macrophage compartment, we also were able to identify several immune checkpoints, namely TNF-RSF14, aka CD270, VSIR, aka VISTA, as well as LGALS9 and CD86. LGALS9 is galectin-9. So all in all, in conclusion, I think single-cell RNA sequencing is a really powerful tool to capture the complexity of all the constituents of the pancreatic TME. And I hope I showed you by this example of the immune cell compartment that a transcriptomic cell atlas can really be leveraged to ask a myriad of questions and hopefully ask some very clinically relevant questions. Then in conclusion, in terms of the immune cell compartment, chemotherapy may induce CD4 as well as CD8 T cell activation, while simultaneously priming tumor-associated macrophages for more immunosuppressive programming. And then lastly, chemotherapy is associated with a checkpoint ligand receptor poor tumor microenvironment. What are the next steps for us? Of course, having all this data and all the cell types at hand, we need to model the complex interactions of all the constituents within the pancreatic TME. We still continue to enroll patients in this study. We're up to close to 50 patients now, and we will continue to validate the findings in this smaller cohort in our growing population. And then, of course, we want to understand the therapeutic response of the pancreatic TME by having matched samples from the same patient, meaning including patients' biopsies just prior to the start of treatment, as well as biopsies on treatment. And then, of course, we want to generate some biomarkers that generate a favorable response to chemotherapy and possibly in the future immunotherapy. And of course, I can't give this talk without thanking the whole Simeone lab. Many people work tirelessly on this project to enroll as many patients as we can. First and foremost, I'd like to thank Diane and continued mentorship throughout all of this, both for me as a surgical resident, as an aspiring scientist. And with that, I'd be happy to take any questions.
Thank you very much, Gregor. So this paper is open for discussion. Jill.
Good morning, Jill Smith, Georgetown. Thank you for that very nice work. I have a question about the next steps. And have you considered doing mass cytometry with CyTOF to look at the crosstalk between different proteins and see what the interaction is in association with these different immune cells?
Right. Yeah, very good question. So any given finding, we want to and we plan to validate in a protein setting. I think you would just have to, just the discrepancies between expression profile and protein profile. We actually are planning on doing multiplex IHC or multiplex IF for those to answer those questions. Yeah.
So I would have a small question, which is probably along the line Jill was just asking. I mean, if you do the RNA-seq of the single cells, wouldn't it be important to have an endpoint so that you correlate it and be less explorative?
Absolutely. So as we keep on enrolling patients in our cohort, and as the project continues for longer periods, we'll actually have those data. We'll have chemotherapeutic responses. We have survival. And as our numbers increase, I think we'll correlate those numbers out for sure.
Over here.
I will go A2 Bio, a nice talk. In addition to SciTalk, we're doing any multi-omics and spatial associations as well.
So we plan on possibly employing nanostring assays to really take a deeper dive into the spatial relationship of various cell types. Yeah, absolutely.
Maher Abdallah, UNMC. Did you get the chance to look on exhaustion markers of T cells, these activated T cells, to see if they are?
Yeah, so we did. I didn't have that shown on the slides. And interestingly, what we see with chemotherapy, a lot of these exhaustion markers, as well as the checkpoints, actually downregulated. Our cohort for this sample of 7 was slightly too underpowered to really make a meaningful conclusion yet, but I hope as our numbers grow, we'll have an answer to that in the future.
Great. Thank you very much, Greg.
Thank you.
So we're moving on to our next talk, and that will be presented by Marta Sand from another Mitris lab. And it's on investigating the molecular underpinnings of neoplastic progression in pancreatic cysts using spatial transcriptomics. So we are moving forward in big data and technology. Looking forward to your talk.
Thank you. So hello, everyone. Good morning. Thank you for coming. And thank you for the opportunity to share our research today. So intraductal papillary mucinous neoplasms, or IPMNs, are bona fide precursor lesions of pancreatic cancer. We heard a great talk by Dr. Wood yesterday on IPMNs. And so IPMNs are actually quite common among the general population. They're often found incidentally by CT or MRI imaging, particularly in the older population. And even though the majority are benign, some will progress to PDAC. And they do so by exhibiting higher degrees of dysplasia through low-grade IPMNs, high-grade, and PDAC. And so it's really important. There's a need for an improved understanding of the molecular mechanisms that are driving the development of this invasive neoplasia. So we can facilitate early detection and interception, and also so that we can help predict the neoplasms that have a higher malignant potential. And so spatial transcriptomics is a new emergent technology that allows you to get gene expression profiles, but directly from tissue samples. And more importantly, you can actually preserve the location of those transcripts. So you can see how they are distributed in the tissue sample. So this really gives you an opportunity to look at cell composition changes, distribution, and gene expression. And we think that was a particularly good application for IPMNs because they are so highly heterogeneous. So in this cohort, we actually started with 3 PDAC samples. So these were high-grade IPMNs with co-occurring PDAC, 3 high-grade IPMNs, and 7 low-grade IPMNs. And so from these, what you can see right here are actually the spots from the 10x Vision platform. And we were able to get 12,685 spots. They were about 55 microns each. And from each of those, we can get information about up to 8,000 genes. So the approach that we took for this study was actually we selected what we call the epilesional or perilesional areas in our data set. And so the epilesional is actually the spots that correspond to the epithelial cells in the cysts. And then the perilesional is the adjacent microenvironment surrounding the lesions. And so by doing so, by selecting these areas, which we could not have done without the spatial component, We then compared the data from these areas between the low grade and the high grade or PDAC group. And by doing that, we found many genes that were dysregulated between these two groups, both in the epilesional and in the perilesional area. And from this list, we saw many sort of expected markers of progression, several mucins, as well as some markers that have been previously reported in single-cell RNA-seq data sets, especially in the epilesional components. And then from the perilesional, we saw, for example, higher degrees of inflammatory markers in the low-grade IPMNs, and then more markers of this desmoplastic stroma in PDAC from cancer-associated fibroblasts. We've also been seeing some intriguing changes in a group of proteins called matrix metalloproteases, which are actually known regulators of the microenvironment. They can cleave collagen and other components of the extracellular matrix. And for example, for MMP1, we saw that those were observed at higher levels in the low-grade epilesional areas, while we saw a higher expression of MMP11, for example, in the perilesional areas, particularly in PDAC samples. Another interesting change that we've seen is from this transcription factor, NKX6 homeobox2, that we actually saw elevated in low-grade IPMN lesions. And you can see in those images, it actually localizes very well to where the cysts are. And this transcription factor is actually known to be important for the differentiation of pancreatic progenitor cells into beta cells, but there's not much known in the context of IPMNs. Nevertheless, in the context of gastric cancer, it has been suggested that it can regulate gastrocin-2 to suppress gastric tumor proliferation. And interestingly enough, we also see gastrocin-2 in our low-grade IPMN epilesional areas. So we hypothesize that there might be a potential anti-tumor role of this transcription factor in IPMN lesions. There's also several studies that are pursuing the detection of the methylation of the DNA of this transcription factor in bodily fluids for potential early detection in other cancers. And of course, as we have heard from the previous talk as well, what's really important is, we have a limited cohort here and we've only been looking at the transcriptomics. So what we really want to start doing now is looking at this at the protein level. So we're starting to do in some multiplex IF. And here's an example for the transcription factor I was mentioning. And you can see on the left side of the screen that we see the co-localization of NK6 on the in the epithelial cells from the low-grade IPMN, while we don't really see that signal in the high-grade IPMNs. And we just started with this validation cohort, but we really want to run a lot of samples and see if those trends hold. Interestingly as well, we have seen overlap between the transcript levels that we see from our spatial transcriptomics with plasma markers at the protein level that have been explored by our collaborators in the Hana group at MD Anderson, potentially further highlighting their role for early detection. And finally, we've also been exploring different single-cell deconvolution technologies. Spatial transcriptomics is not at the single-cell level yet. And so there's several algorithms that you can apply that help you sort of deconvolute the data at the single-cell level. And by doing so, we've been able to see different changes. It's particularly interesting changes in the perilesional areas where we can see, for example, an accumulation of macrophages in the PDAC samples, where we see a higher degree of infiltration of mast cells in the low-grade IPMNs. And so with that, I hope that I have shown you how by selecting these epilesional and perilesional areas from the spatial transcriptomic analysis, which would be, it's really important that you have that spatial component, allows the identification of the signatures that could be associated with IPMN grade and invasiveness. And we see this interesting overlap between the transcript changes that we're seeing from the vision technology and protein markers that support their role as markers for early detection. And we have also applied this RCTD algorithm to perform single-cell deconvolution from ST data. And we have seen these interesting changes in cell type composition in the adjacent microenvironment to the lesions. And so, what I really want to emphasize is we, of course, want to validate these findings at the protein level. We're doing multiplex IF, and we're also working with imaging mass cytometry right now. One thing I didn't have the chance to talk about is we also are doing some spatially resolved CNV and SNV analysis so we can correlate these changes with mutational status. And of course, we want to do functional studies on these promising leads to pursue as potential markers for early detection. And with that, I'd really like to acknowledge everybody that was involved in this project, the great Mitra lab at MD Anderson, our collaborators, also the APA, thank you for the Young Investigator Travel Grant that allowed us to come here and present our work. And thank you for being here today. I'm happy to take any questions.
So thank you very much, Marta. I would have a question. I mean, you pointed out that there are changes in the mast cells. Do you have any idea what the functional role is there? I mean, we've spoken so much about macrophages. We do know a lot, but mast cells are a blank for many of us. So what's your speculation?
Yeah, the truth is we don't know yet. But there's a lot of up and coming studies that have shown that mast cells are also great regulators of the tumor microenvironment. But yeah, at the moment, we hypothesize that here they might be more of anti-tumor and an anti-tumor role, but that's something that we definitely need to explore further.
Marta, nice talk. You showed that there was an overlap between your findings and serum markers. Do you also have cyst fluids from these patients, or have you thought about looking in the fluids?
Not from these same patients, but we do have it from a similar cohort. So that's definitely something we want to look into, particularly for, what we're not sure about is if there's, like, for example, markers from the low grade, so we would necessarily see in the cystic fluid if they actually shed or not. But definitely some of the more invasive markers. But yeah, definitely cyst fluid.
Okay, great. Thank you very much, Marta. Thank you. The next talk is from David Ruddy from Novartis Institute for Biomedical Research, who's already here. The Hana project, targeting cancer one cell at a time. David.
Thank you, and good morning to everybody. Thanks for getting up and early and out for this talk, and thanks to the organizers for inviting me to talk about this exciting topic. So first, I'd like to thank the people involved with this project, and there's been a lot of people. I joke with Andy Liss, our collaborator here, that in the collaboration document with Novartis and Mass General, the Hana project was only 3 sentences in a 37-page document, but it grew to be quite a large effort because a lot of the findings we were sort of finding in that space. So primarily, I'd like to point out John Harrison, who worked in Andy's group. He was the surgical resident sort of interface between our group and the Mass General and the patients. Michelle Piquet, who works in my lab and did all the single cell sequencing. The big lift, and I think people sort of underestimate the amount of lift there is in the informatics space of this, and I listed a lot of people in that space, but primarily Slavica Dmitrieva, who did all the sort of single cell sort of analysis for us. And lastly, Jonathan Chang, who works in our immuno-oncology group, who we call the sort of cell whisperer. I think a lot of people who work in the PDAC space know that in the single cell world, it's very difficult to handle pancreas cells. And sort of we need people in that space who can really sort of manage, keep the cells viable through the whole process. So what is the Hana project? Well, it's a collection exercise. Initially, there was a lot of, I would say, hesitance, I think, at Novartis to sort of partner into the hospitals and actually collect patients. It's a lot of work to get fresh samples out of a hospital and to cross the river and to do this work. There was a lot of late nights. It was very unpredictable in dealing with actual clinicians. You never knew when the patient sample would come out. So, hats off to the Mass General folks and as well to the people at Novartis for actually doing this. In the end, we collected about 38 patients total, 10 control patients. And as well, we're sort of making models from these systems. We're trying to make patient-derived PDXs as well as cell lines so we can do further studies in this space. But in the end, we've generated about 500,000 cells. It's the largest single cell project at Novartis at this point. And we've collected a bunch of different conditions sort of shown there beyond sort of our initial sort of naive approach and going in to collect normal pancreatitis, which is our inflamed non-cancer state. Treated, untreated, there's a lot of different things that can come out of these centers, and we took a lot. So next year. So what did we get? So this is actually a UMAP view, which you'll see a lot of in single cell space. But it's a representation of 19 patients. It's a little over 300,000 cells. One of the things you'll notice right off the bat is that there's a lot of fibroblasts there. In a lot of the data sets that we've seen coming out so far, that the amount of fibroblasts has been very small. Again, hats off to John Chang, who we think did a better job, at least in handling these cells to kind of keep the fibroblasts alive through the whole process. And we also show on the bottom there sort of canonical markers, and you've seen that we have a really clean data set here that we're very proud of. And lastly, there's sort of a bar plot to sort of view all those cells bucketed by the sort of 4 collection types that we were after, mainly the normal, pancreatitis, the untreated set, as well as the treated set. And what you'll see there, it's sort of boxed off to make it obvious, but you see this sort of increasing amount of fibroblasts in the sample sets there. You can also sort of see boxed off in the bottom there, the amount of tumor cells. You see that there's only 7% of tumors in sort of our untreated samples. It's a very small amount of cells. And it was a little new to us in sort of our space to think about cancer and this cancer microenvironment as being such a small piece of it. But it's something that's sort of important to note. We do see sort of reduction in the sort of amount of cells with treatment, but still there's plenty of tumor cells in that treated cell. One of the things we're quite proud about is that we get a lot of questions early on when we started presenting this data about how confident we were in calling tumor. So we spent some time developing an assay, which we call the K-Ras assay, which allows us to amplify the genetic region from G12, the G12 position all the way to the Q61. We're able then to fix that genetic information to the actual single cell barcode. We're able to map that information back onto our UMAP plot. So what you see there on the right in that UMAP plot is we've now labeled a cell with its actually K-Ras status in the patient collection. So we can actually say with very high confidence that the tumor is actually tumor in this setting. What you'll also notice is that we see a lot of wild type in the other cell types and very little presence of any sort of K-Ras mutant there. So again, there's no tumor cells masquerading as some other cell type in the data set. The tumor is tumor, and all the other cells in sort of a wild type state. And you can sort of take these cell views and sort of blow them up. Here, we've taken out the normal ductal and the tumor section and sort of done a reclustering to sort of get a little bit more specificity. And we've again mapped the K-Ras status of these cells in this cluster map to the view. And what you can see there, and it was sort of interesting to us, is that there seemed to be a little bit of a discrepancy or a difference between the G12C cells and the other cells, enough so that we went back into the TCGA data and asked the question, is there a difference between patients that present with these mutations in their survival? And you can see it in that plot there, in the survival plot, that there is a significant, a pretty big difference between G12D and others here. And you can even see it in our own data set. And I put that down at the bottom. We're seeing already our G12D patients progress much sooner than our other patients for G12 other here. And I just recently sort of actually hit the sort of significance value of 0.03. So put this slide up sort of briefly just to show what standard of care looks like. Top one is the sort of is the target for irinotecan. You see there's very little difference in the sort of tumor ductal difference. It's something that you sort of think of for clinicians. I put this up for clinicians view. TIMS is also the target of 5FU, and you see a little bit of more specificity in the tumor space. But again, there's not much difference in the tumor normal side. Below is top 2A, which is a much more specific marker of differentiating cells. I put it alongside MKI67 there to sort of show you that as well. And again, for us, it's always comes down to sort of this big plot of a differential. I've highlighted normal genes that sort of mark normal ductal on the left and a selection of genes that mark tumor on the right. There's a bunch of genes marked out there. K-Ras is noted as well as sort of some known genes that are already sort of assets in the clinic. One of the things we're excited about too is this tumor receptor ligand analysis you can do. We can now start asking questions of tumor receptors versus ligands in the milieu. And this is something we've actually put onto our entire data set now. And this is a selection of data in this sort of untreated versus normal setting. I've highlighted a few that are important in Novartis because we have assets in that space. And we've done some follow-up research already on this to show that you can sort of take, this ligand met in sort of CCLE lines and treat them and see an effect, and it's sort of highlighted through there. And sort of lastly, this is sort of the piece that we're working on now. We're actually taking our patient models in PDX. We're taking these large gene lists that we've generated, and we're doing CRISPR libraries to see if we can actually show dependency in these systems. I think a lot of the sort of feedback we've gotten in Novartis that oftentimes expression doesn't mean dependency. You can see differentials in expression spaces, but it doesn't mean the cancer cell necessarily is dependent upon it. So we're working on that now. We expect to see results hopefully for next year's conference. But that's it on one time. So thank you.
Thanks, David. I would have a question regarding your K-Ras, say, tagging assay. I mean, you define the tumor cells by K-Ras mutations, if I'm right, and we all agree that 95% of the cells will be K-Ras mutated. But what about the 5% which won't? Would that actually change your results tremendously and maybe mislead you?
So, we spent a lot of time, Andy and I, discussing the wild type cells. So we do see a pretty decent number of cells that we're calling wild type by this assay. One of the issues with the assay itself is K-Ras is not expressed at huge amounts. So we only get a value back if we see expression in the cell. I mean, you often hear about this thing of sparsity in single cell data where you get very little expression for certain genes. So we're sort of looking into that now to try to understand that, because in our space where you're starting to see molecules coming out treating specific K-Ras variants, we're going to wonder what's going to happen with all those wild type cells and how they'll survive the treatments.
And can you say anything about K-Ras dosage? Because I mean, we now learned that that affects tremendously the carcinogenesis.
Right. So dosage, when you say dosage, you mean the amount of K-Ras variant versus the wild type in that setting? Is that what you mean?
And also the activity, yeah. So a copy number variation.
So we don't have any data to talk to that yet. It's a very interesting question, but it's something I think we sort of it's sort of things we talk about in bars, I find, but we haven't quite got that into the lab yet. Go ahead.
Hi, Diane Speroni, NYU. Very nice talk. Just to follow up on Julie's point, why not do copy number analysis? That's actually going to be much more effective in defining which cells are cancer and which cells are not, rather than just looking at K-Ras.
So it's a good point. A lot of people and a lot of work out there, they do sort of copy number. For me, in sort of the drug discovery phase, I feel like what cancer really is a mutated K-Ras. That's kind of what I feel. And again, I think we can debate this probably, but to me, the easiest way to define cancer, especially in the expression space, is K-Ras. I'm ready.
No, I'm just saying we know that patients with chronic pancreatitis have K-Ras mutations and they don't have cancer. So just to highlight that point for you to think about.
We've seen very little of that in our pancreatitis samples, but we don't have a lot of patients targeted against that.
I was intrigued by your G12D survival data. Have you seen any different signatures in the G12D tumors versus the other tumors that may explain?
So we have, when you
biology?
do differential expression, you do see some difference there. And we've incorporated some of those genes into our in vivo set to try to look at that. But it's not, it's not like it's wildly striking. You know what I mean? It's not like there's a lot of genes that pop out and be like, oh yes, there's your target. It's not like that. We don't really feel that yet.
Well, let's hope some of these G12D allelic specific inhibitor campaigns are successful in the near future.
Well, that's what our hope is too.
Cool. Great.
All
Great
right,
talk.
thank you very much, everybody.
So our next talk is going to be given by Thomas King. He's from Immunovia. We know that there's a clear application for a new diagnostic assay developed by Immunovia, and he talks about the IMRAY PanCan test performance and CA19-9 results from the blind validation study.
Thank you very much. Thank you for the opportunity to speak today. Today I'm going to describe for you our blind validation, which was done in collaboration with many sites in both the US and Europe, and involved 167 PDAC cases, 56 of which were stage 1 and 2, and a large number of individuals from our PanFlam clinical trial that involves patient samples collected prospectively from surveillance studies in both the US and Europe. These samples all came from US sites. We also included healthy controls in our blind validation study. Our assay is a multiplex protein assay based on serum. It involves the detection of 8 immunoregulatory and protein-associated biomarkers using our IMRAY technology, which uses single chain variable fragment antibodies bound in a microarray to slides, which are detected by immunofluorescence. That's combined with a CA19-9 assay done by conventional clinical means. And what we've done is develop a mathematical model that derives a decision value from the combination of the levels of these different proteins and oligosaccharides, combines them together and generates a decision value. A negative decision value is predictive of the presence of cancer, and a positive one of not cancer being present. I wanted to talk a little bit about the demographics of these samples. Our PDAC samples had a median age of about 70 and were predominantly male, as you would expect. Our PanFam cohort was a bit different. It was about 10 years younger, which is not surprising in a surveillance group, and was predominantly female. A substantial percentage, almost a third of these individuals had had prior cancer, which is not surprising given that many of them have germline mutations that predispose to PDAC as well as to other tumors. And Dr. Lucas from Mount Sinai will be speaking more about our PanFam study during lunch today if you're interested in hearing more about that. Our healthy controls came from both the US and Europe. In the US, this was an ethnically diverse group. I wanted to highlight the number of cancers and the types that were occurring in the surveillance group, predominantly breast cancer, but a wide variety of different cancers. The individuals in this group also were not particularly healthy. And I've listed the 600 and so medications that they were individually taking in terms of the individuals we looked at in this study. This assay was performed in our lab in Marlborough, Massachusetts, in preparation for the clinical launch of our assay, which occurred this summer. And this was done with fully validated standard operating procedures and instrumentation, along with custom developed and validated information technology that allowed us to scan the slides and combine that information with the output of CA19-9 results from a Roche clinical instrument. So this is a fully clinically validated study that we have performed. And this shows the results in terms of decision values. You can see to the right of this slide in blue and green, the results for the two control populations, our PanFam clinical trial and healthy individuals, which show very similar bell-shaped curves in terms of decision values. And this is in contrast to the red, which is the PDAC samples, which show a much wider distribution and a spread that is much wider and very much shifted towards negative values. This shows the totally independent study that was used to derive the model for our test and shows a very similar distribution. This was done with entirely independent samples about a year before our blind validation. So I think that adds weight to the significance of this test in discriminating cancer from not cancer. These results then correspond to a specificity of about 98% in the PanFam population, with a sensitivity of 85% in early stage disease and slightly higher 87% in all stage disease. We felt these results were quite good. The healthy control group showed a similar distribution with slightly higher specificity. As I thought about bringing this test to clinical use, I really was very concerned about the genetic variation in the percentage of individuals who cannot produce CA19-9 because they have defective copies of the Lewis antigen gene. And this shows the biochemical pathway by which this oligosaccharide is formed. The terminal step to convert to CA19-9 is dependent on the Lewis antigen. And previous literature shows that individuals with two defective copies of the Lewis antigen gene have very, very low resting levels of CA19-9. So there's also substantial ethnic diversity in the frequency of these mutations. And in the US, some ethnic populations have up to 25% defective Lewis antigen genes. So based on this, I was very concerned about releasing our test to a population. And as a result, I looked at excluding individuals with very low CA19-9 levels from our study and potentially from the way we would deploy the test in the United States. This resulted in the elimination of about 55 samples and increased our sensitivity for early stage detection to 89% from 85%, and for overall detection up to 92%. We felt that this is really clinically important, and this is the way we've launched the test in the US. So we exclude samples that have very low CA19-9 levels, with the presumption that these individuals are genetically incapable of forming CA19-9. If you look at the percentage of groups that were eliminated from the study based on CA19-9 levels, this was substantially higher in the US cohort, which was much more ethnically diverse than any of the other cohorts. So that makes sense in terms of the ethnicity of the individuals in these different cohorts. We also felt it was important to look at individuals with low CA19-9 levels, to look at the 8 biomarkers without CA19-9. And this shows a ROC curve of the results from this very limited number of individuals, excluding CA19-9 from the decision values. And this result, I think, really shows fairly substantial discrimination between cancer and not cancer without CA19-9 in this group. And I think offers the possibility going forward of developing an alternate cutoff or an alternate model that will allow us to address this fairly significant group of individuals, up to 25% in some ethnic groups. Thank you, and I'll be happy to answer questions.
Thanks a lot. The paper is open for discussion. So I was just wondering whether you also included other controls like chronic pancreatitis patients or patients with different adenocarcinomas to look for specificity.
Had only a very limited number of other cancers in the study. Our PanFam group included many individuals with imaging abnormalities in their pancreas, some of which I think correspond to chronic pancreatitis. About a third of that group that we looked at had IPMNs of various sizes.
Morning, can I ask a question?
Hi, Tom, nice work. I know you haven't released the longitudinal PanFam data, but I was wondering if you could give the audience a sneak peek to help us understand the timing of a positive test with the clinical presentation of pancreas cancer.
Thank you, Diane. Well, unfortunately, this is a very manual test to perform. So our bandwidth in terms of analyzing the 4,000 samples in the PanFam clinical trial has delayed us in getting those results. Amy Lucas from Mount Sinai is going to describe the results from Mount Sinai, which we just completed during lunchtime today. So I think you'll get more of a preview there. But we hope to complete this study in Q1 and have the results available for everyone in Q2 next year.
Thanks a lot. If there are no more questions, we should probably move on. And you just have to know us from the back whether Jason has handed in his presentation. Yes? Okay.
Great. Next talk is from Jason Pthl from UPenn. Collateral amplification of the K-Ras linked gene PTH-LH governs pancreatic cancer growth and metastases and reveals a new therapeutic vulnerability. Jason.
First of all, I'd like to thank the organizers for inviting me to give this talk today. It's a big honor where I'm going to tell you a story about how we came to uncover an oncogenic and pro-metastatic role for the K-Ras linked gene PTH-LH in pancreatic cancer. And I'd also like to thank Dr. Simeone for highlighting how K-Ras amplifications are important for pancreatic cancer, because hopefully I'm going to tell you about a gene next to K-Ras. It seems to be auto-advancing. Okay, I apologize for that. So as Dr. Biankin established last night, there are, over the last decade, been a series of studies that have come out to establish that there are subtypes of pancreatic cancer. In all three of these studies, they showed that there was either a quasi-mesenchymal, a basal-like, or a squamous-like subtype that represents somewhere between a third to a quarter of patients that have a more aggressive form of the disease that decreases survival. Now, more recent work has tried to establish some of the molecular mediators that are potentially driving these processes and driving this squamous subtype. One paper is shown here amongst many. This is from Chris Vaykoch's group, where he showed that the transcription factor TP63 drives a transdifferentiation to the squamous subtype, where it unveils so-called squamous identity genes, one of which is PTHLH, which I'm going to focus on for the remainder of my talk. Now, at the same time, there was other groups interested in figuring out mechanisms that were driving metastasis, particularly genomic events. And when they analyzed patients and looked at the amplifications that were present in metastases at a higher rate than they were at the primary, they found that only the K-Ras amplification was enriched in that setting. And follow-up work established when they had multiple biopsies that if they took initial biopsy in the primary tumor, they found that it was in part of the classical subtype, but when they had a follow-up progression tumor in the metastatic liver, that it was part of the squamous subtype. And when they tracked K-Ras amplifications, they found that there was only amplifications in the squamous metastatic subtype. Now, this excited us because we were studying at the time this gene PTHLH, which we knew was directly adjacent to K-Ras, and we hypothesized that it might explain both of these phenomena. So it's a squamous identity gene that might be driving metastasis directly adjacent to K-Ras. We first looked at the TCGA, and we established when we looked at copy number gains that PTHLH was in fact co-amplified along with K-Ras. We're calling this a collateral amplification. And again, we see this in about a quarter of patients. We validated this in cell lines. I'm showing you 2 pancreatic cancer cell lines here for DNA FISH for PTHLH, and I've highlighted the nuclei with yellow dotted lines to show you that there are multiple copies of PTHLH in pancreatic cancer cell lines, but not the normal human pancreatic ductal epithelial cell line. Why does this matter? Well, if you look at the DNA, RNA, or protein, PTHLH expression correlates with decreased survival. We also collaborated with Fayez Noda's group to get access to some stage 3 and 4 patients in the COMPASS trial, and we found that the metastatic patients or the basal-like and squamous patients had an enrichment of the PTHLH copy number. And what is PTHLH? Well, PTHLH is the parathyroid hormone-like hormone. That's the gene that encodes for the PTHRP protein. It was first described as the causative factor of hypercalcemia of malignancy. It very much mimics in its active form the parathyroid hormone. They both bind to the same receptor, and they're both known to induce things such as cytosolic calcium release and can be pro-proliferative. This is what PTHLP signaling looks like. I don't want you to focus on the details. I just want to highlight a few things that I think might be upregulating PTHRP in pancreatic cancer. So ETS transcription factors downstream of RAS-MAP kinase, SMAD transcription factors in EMT and TGF-beta, as well as the squamous identity transcription factor TP63 that I previously highlighted. All this signaling often culminates in activation of CREB and RUNX, which themselves have been shown to be oncogenic in pancreatic cancer by other groups. So when we first really started to dig into the data, we stained for PTHLH in a series of mouse tumors from either Panin lesions or KPC PDAC tumors. And in collaboration with Anirban Matra, we showed that there was a stepwise upregulation in PTHLH expression from Panin to non-metastatic primary PDAC to metastatic primary PDAC. Importantly, we have the YFP lineage label here, so we can trace our tumor cells at the metastatic site, here shown in green with staining for PTHRP in red, establishing that the metastatic tumors continue to express PTHRP. Digging into other people's data, we found that, again, the metastatic samples had higher expression of PTHRP, as well as metastatic CTCs. To start performing some functional data, we first knocked this down in a series of KPCY cell lines. I'm showing you one such cell line here. We then performed orthotopic injection back into the pancreas, and we found that there was reduced primary tumor burden, as well as the percentage of YFP positive cells in the liver. In other words, less metastatic burden. I do like to highlight that these cells have a modest but statistically significant reduction in proliferation, which I think might be important for some of the phenotypes I'm going to show you. We performed CRISPR and got complete phenocopies, and if we did PTHLH overexpression, we also were able to show that it was sufficient to enhance growth. Now, one problem with this cohort is that the smaller primary tumor might be affecting metastatic competency, so we repeated the assay this time with a second cohort of PTHLH knockdown tumors, which we allowed to grow twice as long, such that their primary tumor burden was roughly equivalent to the controls. And again, we found no evidence of gross metastases by YFP positive tumor cells. This convinced us to build the full KPCY PTHLH deletion animals using flox alleles, and I want to remind you that it's directly adjacent to K-Ras, and it was therefore the odds were very low of us getting homozygous LOXP animals with mutant K-Ras. So for the rest of the talk, I'm going to focus on heterozygous deletion animals, we got a dramatic survival advantage upon PTH-LH deletion, which we largely attributed to the fact that these animals were non-metastatic, despite the fact that they were roughly 3 months older. Because we have the YFP lineage label, I can show you the primary as well as the metastatic tumor burdens, and I think we can really even see micro or milli metastases with our YFP positive tumors. So we're quite confident in our ability to call metastases. Fortunately, some collaborators at McGill University, Richard Kremer's lab, have made monoclonal neutralizing antibodies against PTHRP. We showed that we could again reduce primary tumor burden in an orthotopic assay, as well as the metastatic ability. If we did a forced metastasis assay through a tail vein injection, we could again reduce colonization by multiple measures with anti-PTHRP therapy. And finally, returning back to the KPCY model, we were able to show in collaboration with Honorbon Matra that these animals have reduced percentage of poorly differentiated tissue, which I think is best illustrated by looking at YFP, our tumor label, and ECAD here in our epithelial cell marker. In KPCY animals, we have a lot of YFP positive, E-cadherin negative EMT disseminating tumor cells that are completely absent in the PTH-LH heterozygous deletion. This was quite a dramatic phenotype. Now, finally, we did some RNA-seq to try to figure out the downstream mechanism, and perhaps unsurprisingly, given the in vivo phenotypes I've shown you, we saw a reduction in EMT and TGF-beta signaling, with a lot of the major players being down upon PTH-LH reduction. And if we tried to even force an EMT, this is a flow cytometry-based assay where we're measuring E-cadherin. In the control cells, we could easily induce EMT, but the PTH-LH knockdown seemed to be completely recalcitrant. Again, illustrated by staining for E-cadherin, I think you can appreciate that ECAD does not go down upon PTH-LH deletion after TGF-beta induction, this is quite a high dose of TGF-beta. And really quickly for downstream mechanism, we think this is important for colonization. Particularly, we found when we dug into our RNA-seq that SPP1, which encodes for the osteopontin protein, was the #1 gene upregulated in controls relative to knockouts. And we established that this was downregulated. And when we forced an overexpression of this in our knockout cells, we were able to at least partially rescue the metastatic phenotype, suggesting this is one component of the downstream signaling. So hopefully today I've been able to convince you that PTH-LH is potentially a new driver in pancreatic cancer that is enhancing both primary and metastatic tumor growth. We think it's important for ENT and dissemination. Work I didn't have time to show you today is that we think this is occurring through autocrine signaling, where the tumor cell makes it and secretes it onto its nearest neighbor, and that we think K-Ras amplifications might be driving this entire process. I'd like to thank my co-mentors, Anil Rusky and Ben Stanger, who have been incredibly supportive, as well as the people who have helped me throughout this very collaborative project.
Great. Paper's open for discussion.
Can we what the antibodies? Sorry. Yeah, the drug treatments that I showed you were neutralizing monoclonal antibodies directed against PTHRP. So yes, we're able to reduce primary as well as metastatic tumor burden. We think this is largely occurring through a reduction in proliferation.
I was just wondering if because with hyperparathyroidism, the PTH levels in blood are actually what are used to even guide surgical resection. So I was wondering if you had looked at the levels of this protein in the blood of pancreatic cancer patients.
Yeah, so it's quite an interesting protein. So PTH we think is acting in an endocrine fashion where we would see it in the blood, but we think PTHRP is more of an autocrine paracrine signaling in the local tumor. When we tried to look in blood, we haven't yet found it. I will say that the assay that measures PTHRP is not a perfect assay. So it's a really tiny peptide. It's only 34 amino acids, and it's very hard to measure in the blood. So you have to have, I think, really fresh blood to measure it, and we're currently doing that now.
Thank you.
Gloria Su from Columbia University. I was wondering, I think you might have heard my question before.
I think so, yeah.
So I was wondering whether have you had a chance to look at human sample that have lost the wild type K-Ras and see if PTH is retained in those samples.
So we did look and it was not retained, but it was very small numbers of patients. So unfortunately, I don't know if we have any power to really determine whether PTH-LH, in other words, can we decouple it from K-Ras? I don't think we have the power yet to do that. But if anybody has such a data set where potentially have K-Ras amplifications, but don't have PTHLH amplifications. They're only 2 megabases away. So I think that's going to be quite rare patients, but I'd happy to look at it.
All right, thank you.
Thanks.
From a very broad perspective or a bird's perspective, if you would interfere with the calcium homeostasis, the phosphate homeostasis, do you think you could influence metastasis formation?
Yeah, absolutely. So in quick follow-up work, if I can summarize it, we showed that PTHRP activates release of calcium from the endoplasmic reticulum. And we showed that the calcium ion itself is driving a partial or hybrid EMT state. And if we block that we could block the EMT. So I think we could block the initial dissemination and potentially have less metastases.
Thanks a lot.
Thanks.
Very good talk. So we move on to our next talk, which is presented by Guru Trikudanathan. I'm sorry, Guru. I know you by face, but it's very hard to pronounce your last name. And you're going to talk about genetic pancreatitis variants are associated with different pain phenotype before TPIT, preliminary data from the post-cohort.
Good morning, everybody. I'm Guru Trikudanathan. I'm one of the advanced endoscopists and medical pancreatologists at University of Minnesota. I would like to thank American Pancreas Association for their generosity. This study would not have been possible without the Young Investigator Award, which was awarded to me last year, and also NIH for awarding the R01 for Melina Bellin for the study. TPIT, as all of you know, is indicated for severe chronic pancreatitis, as well as recurrent acute pancreatitis, which is refractory to medical and endoscopic treatment. And in TPIT, we remove the whole pancreas with the goal to mitigate the source of pain and to improve the patient's quality of life. We also harvest the islet cells from the explanted pancreas and inject it back into the portal vein with the goal to prevent or minimize post-surgical diabetes. TPIT is increasingly adopted across centers in the United States. And while it has really good outcomes in 85% of the patients, roughly about 15% of patients report pain after TPIT. Their quality of life is still impaired. And also 40% of the patients, we are not able to wean them off opiates completely. So in roughly 1 in 7 patients, there is a failure in TPIT, and we currently do not have any predictors to predict which among this 1 in 7 failed. So with this in mind, we were looking for predictors, and one of the things which came up to our mind was, why not look at genetic markers? So we were interested in genetic mediators of pancreatitis and opiate responsive genes, and we were interested in seeing how they would predict the surgical phenotype. The pharmacogenetics for opiate metabolism and bioavailability is extremely complex, but there are some genes where the mutations in the metabolic pathway, including the receptor pathway and a transporter pathway, if we thought that these are some genes which could affect the opiate bioavailability, and we were interested in these genes. The genetics, as far as pancreatitis is concerned, is fairly well known. There are 3 main pathways: the trypsin pathway, the ductal pathway, as well as the endoplasmic reticulum pathway. And what we also know about the genetic pancreatitis is they carry a distinct immunophenotype. There was a recent study published by Ida and Melina Bellin from the Stanford group, where they looked at the immunophenotype from genetic pancreatitis, and they identified a T-cell predominant infiltrate versus the idiopathic pancreatitis, where it was a macrophage predominant infiltrate. So all this suggests that genetic pancreatitis has a distinct immunopathogenesis. And also clinically, MUSC conducted a retrospective study among 195 patients, where they identified that patients with genetic disease have a higher likelihood of opiate cessation and had a higher quality of life. So, but what we do not know as far as genetic pancreatitis is concerned is that not all adult patients have genetic testing. It's done in pediatric population, but not all adult patients undergo genetic analysis. When they do undergo, it's not the entire gene panel they undergo, so it's always incomplete. And also the pharmacogenomics, like genes which mediate opiate responsiveness and bioavailability, have not been included. So we thought that complete genetic testing for the same gene using the same methods in the entire cohort, in a scientifically valid and rigorous approach, was really needed to identify genetic mediators. With this in mind, we wanted to determine in our study if patient phenotype at baseline is associated with the classic pancreatitis risk factors, as well as variant in opiate receptor pathways. We were interested in a subset of patients after 1 year follow-up and to see if the opiate pathway variants could predict the opiate use, the pain scores, and the quality of life 1 year following TPIAT. The post that we used, the post cohort, the post is an ongoing prospective evaluation for TPIAT. It's led by Melina Bellin. It's across 13 centers in the United States, and we leverage some of the post infrastructure, and we used some of the salivary samples in the preliminary post cohort, and we perform next generation sequencing for these patients. And genes we were interested were in the trypsin pathway, the ductal pathway, the endoplasmic reticulum stress pathway, as well as some genetic modifiers. And the genes we use for the pharmacogenomics was concerned were, again, genes which impacted the opiate metabolism, the bioavailability, the receptor responsiveness, and some addiction and analgesia sensitivity genes as well. And the clinical outcomes we were interested were both at baseline and at 1 year follow-up, where pain measures. The pain measures, we determined that by the visual analog score, by the opiate use at baseline, the T-score for pain interference. We were also interested in the quality of life. This was through the SF-12 questionnaire, which had a physical and a mental component, as well as the diabetes at baseline as measured by the fasting glucose and the C-peptide and the islets at the time of explant. When we go to the results, we were able to do this study in 195 participants, and 56% of these patients had genetic variants for pancreatitis. And what we identified were in specific phenotypes at PRSS1. PRSS1 patients had a lower average pain at baseline. They were less likely to have opiates at baseline. They had a lower pain interference score at baseline and a higher physical component of in the quality of life score. Participants with SPINK1 mutation had higher fasting glucose. They had a lower islet mass at baseline after adjusting for the disease duration. And participants with CF mutations, the Delta 508, had higher fasting glucose. Also, interestingly, at baseline, there were some opiate receptor variants which were associated with distinct pain patterns. The mutations in OPRM1 gene, which actually codes for opiate mu receptor, we had like 20% lower average pain score and lower pain interference scores as well. But what was very novel was what we saw 1 year following TPIAT with the opiate responsiveness genes. The ABCB1 and some of the CYP250 pathway genes, we were able to identify some genes which had a twofold average pain score at 1 year following surgery, as well as a 99 points lower on the physical component score, and also higher frequency of opiate use 1 year following TPIAT. So to conclude, genetic disease were very common in our TPIAT cohort, which was not surprising. And those with PRSS1 variants had lower pain burden and were less likely to use opiates. This was because predominantly the PRSS1 patients were pediatric patients, and the providers were willing to refer these patients earlier in their disease course. So that's why we saw that the PRSS1 had a lower pain burden. Then the SPINK1 mutation variants had a more extensive disease because they had higher glycemia as well as lower islet mass, suggesting an extensive disease and more islet damage. And as I mentioned, the ABC1 variants, they appear to increase the odds of persistent opiate use by roughly 7-fold, but we had a wider confidence interval, and we need more data to validate this. And again, this is an ongoing study. This is just a preliminary sneak peek. We hope to, validate this in the entire post cohort. And optimistically speaking, if we are able to identify genes, then we could do the personalized pain management before and after TPIT. This will lead to a better outcome. And I would like to thank all the participating sites in the post consortium, and thank you so much for this opportunity.
Thank you very much, Guru. The paper is open for discussion. So how can you exclude the bias where you have, say, pain or from onset of the disease to TPIT, where you would think that there is some development of pain memory versus really genetic predisposition predisposing you to opioid mediated.
As you rightly mentioned, the opiate cessation is a very complex theme, and a lot of patients have this central pain sensitization, and that's why we are trying to predict which ones would have pain sensitization. That's a different study in the post consortium, and we are also trying to look at the genetic genes as well.
Hi, Guru. Very good question and very difficult study.
Right.
As Julia points out, if you look at pancreatitis risk genes, I mean, using the pain phenotype alone, you don't know what you're really looking at. The fact that SPINK1 carriers have more severe disease have been documented in many other studies.
Mm-hmm.
And basically, it stands to reason they may have different pain phenotype as a consequence of the more severe disease.
Right.
So, and for the other ones, it's difficult to judge because you're not showing us the statistical data.
Sorry?
For the different opioid genes, we don't see the confidence interval.
Right.
So-
Again, this was a very preliminary analysis, and we are hoping to show more in the publications which we are working on.
But I think it's a good attempt to clarify this, which many other people tried, and it's really not clear if there's a genetic basis for pain in pancreatitis. Thank you.
Thank you very much. The next talk is from Arsen Ospov from Cedars-Sinai, identification of focal adhesion kinase as an immunosuppressive signal on tumor-associated neutrophils and macrophages and anti-PD-1 antibody-treated pancreatic ductal adenocarcinoma. Arsen.
Thank you for allowing me to speak today. I'm a GI medical oncologist from Cedars-Sinai. Our group has really been focused on trying to target and investigate the tumor microenvironment and stroma to develop a therapeutic strategy that's effective in pancreatic cancer. And we focused on focal adhesion kinase, or FAK. And focal adhesion kinase is a non-receptor protein tyrosine kinase. It's been implicated in numerous cancers and proliferation, differentiation, and signal transduction. It modulates the immunosuppressive elements of the tumor microenvironment, as I'll come to show you. There's implications of its impact on effector T cell infiltration and as a potential radiosensitizer. Now, our group utilized a neoadjuvant clinical trial, which provides actually ample tumor specimens to be able to study the tumor microenvironment and particularly the role of focal adhesion kinase. And in our study, this was a window of opportunity study that focused on vaccine in combination with anti-PD-1 therapy. Now, using the tissue specimens from this clinical trial, we did a comprehensive tumor microenvironment evaluation using a technique that was co-developed by our group and Lisa Kusin's group, where using a sequential staining and stripping technique, we were able to go through 30 different biomarkers for quantitative and qualitative analysis of various cell phenotypes. Over this recent time, we've also developed a very novel panel that's focused on focal adhesion kinase and the stroma, particularly fibroblasts, and its associated immune cells in order to understand their relationship. Using this technique and surgical specimens from the clinical trial I mentioned, we found that actually focal adhesion kinases really expressed in multiple cell types, particularly myeloid phenotypes, such as tumor-associated macrophages, carcinoma-associated fibroblasts, and in a wide variety. Then we did a little bit of a deeper analysis looking at the association and relationship between FAC expression on these phenotypes and CD8 T cell infiltration. We saw that a higher FAC expression among the entire tumor was associated with lower CD8 infiltration, and that a lower density of phosphorylated FAC among neutrophils and M2 subtype macrophages, but not M1, was associated with a higher infiltration of effector CD8 cells. Now, previous data by Dr. DiNardo's group from Washington University actually showed that the role of focal adhesion kinase inhibition in a preclinical model where it decreased the CXCL12 expression, as well as important immunosuppressive myeloid cells such as granulocytes and tumor-associated macrophages. In our lab, we actually used a hemispleen pancreatic mouse model to be able to really understand the role of focal adhesion kinase inhibition in this hemispleen model. By dissecting the spleen and implanting KPC tumor cells, we're able to really understand and kind of show what the tumor would do and test focal adhesion kinase inhibition. In using focal adhesion kinase inhibition, in addition to anti-PD-1 therapy, we were able to prolong survival, and the addition of FAC inhibition to PD-1 increased effector CD8 population. When we analyzed carcinoma-associated fibroblasts, we saw that a higher FAC intensity on these fibroblasts was associated with lower CD8 infiltration. All of this preclinical data together provided rationale for the development of a novel phase 2 clinical trial looking at anti-PD-1 therapy with pembrolizumab and a FAC inhibitor, defactinib, following chemotherapy as both a neoadjuvant and adjuvant treatment in pancreatic ductal adenocarcinoma. This clinical trial is now active at 2 sites at Johns Hopkins University and as well as Cedars-Sinai. We've already enrolled 13 patients, and we're able to not only test these drugs, but more importantly, understand the role of focal adhesion kinase inhibition in pancreatic ductal adenocarcinoma. Now, our group has also looked at targeting the stroma using a drug such as PEG-PH20 or hyaluronidase, and we were able to show previously that by depleting the extracellular matrix, this decreased the CXCL12, CXCR4, and CCR7 immunosuppressive pathway, and then subsequently led to an increase in the effector CD8 population. So the question we asked is, if you're targeting the extracellular matrix, could you potentially synergize this with focal adhesion kinase inhibition, which is an intracellular signal? So then we proceeded ahead and we've conducted this preclinical experiments, which I'm about to show you, where PEG-PH20 we found synergizes with focal adhesion kinase inhibition to target the stroma, and that this leads to an enhancement in survival, as we can appreciate with the triple combination, and that particularly it actually targets cells which are larger, such as myeloid cells, and we see that that's where the FAC expression is most changed. We then focused on looking at the impact on CD8 T cell infiltration. We saw that PEG-PH20 or hyaluronidase enhances FAC inhibition and PD-1 by inducing CD8 T cell infiltration into the tumor microenvironment with a very specific increase in effective memory T cells and a decrease in the naive population. We found that FAC inhibition augments hyaluronidase and anti-PD-1 mediated reduction of myeloid cell infiltration. And again, specifically, the triple combination of these drugs decreased the granulocyte population, the GMDSC population, which are considered to be immunosuppressive, as well as MMDSCs. We then focused on seeing what would happen to CXCR4 expression based off our previous data. We found that targeting the stroma with PEG-PH20 in combination with FAC inhibition and anti-PD-1 altered the immunosuppressive environment by decreasing specifically myeloid CXCR4 expression, particularly on the granulocyte population. We then asked the question is, maybe instead of using PEG-PH20, could you directly target CXCR4? And the combination of CXCR4 antibody may potentially lead to a clinical response and improvement in survival. So we did a combination of FACI anti-CXCR4 and anti-PD-1, we found that actually we looked specifically in our hemispleen model to see the development of micrometastasis, where the triple combination and the addition of anti-CXCR4 led to no metastasis in the mice that were treated as compared to the untreated or even the FAC and anti-PD-1. There was a significant difference in these. And this provided the rationale for us to continue in the future to explore the combination of FAC inhibition, anti-PD-1, and anti-CXCR4, which may be an effective treatment strategy in pancreas cancer. And with that, I'll conclude. I particularly, there's too many people to thank, but I do want to thank my mentors, Dr. Lei Zhang and Dr. Pandal, who've been very instrumental in a lot of this research.
Paper's open for discussion.
Thank you for that good talk. Jill Smith, Georgetown. Did you look at other FAC-associated proteins like paxillin or any of those other ones to see if they were regulated also with your inhibition?
Not that specific protein, but in our multiplex IHC panel, there are other proteins that we've looked at that are relevant to the pathway. Our biomarker panel covers about 45 biomarkers. I've only presented just a few of them here.
Mm-hmm. And do you think it's due to the decrease in the fibrosis or the effect on the EMT that's having the effect on the metastases?
Probably it's a combination of both, but at least in our data, there is definitely a decrease. And actually with Dr. Donato's group, there is a decrease in fibrosis. That's probably one of the driving factors. But what the interesting thing about focal lesion kinase, it affects fibrosis, but then simultaneously the other immunosuppressive cells, which I think are the bigger contributing factor as well.
So that could be a secondary effect.
Correct.
Yeah, thank you.
In your study, how many patients did you recruit which were MSI? Because I mean, for the checkpoint inhibitor therapy, you would at least ask for that.
Yeah, we do look at that right now. That we don't have any patients that have been MSI within our particular cohort for the phase 2 study.
I might have missed this, but what cell type in the microenvironment do you think is the highest FAC expressing cell type? With your anti-FAC therapy, which cell types are you hitting? I know you showed that there's a better immune infiltrate, but
Yeah.
what's the mechanism by which that's happening?
One of the ones that we're really focused on, and it's a very high FAC expressor, is actually the carcinoma-associated fibroblasts. And that's actually a lot of our direction of our future research.
Yeah. When you inhibit FAC, do you change the phenotype of those cancer-associated fibroblasts?
That's an excellent question. And that's actually part of a grant that we have, and that we're actually looking at various phenotypes from myofibroblastic, antigen presenting to see actually what happens with these. And we have with Dr. Pandal, a co-culture system where we'll take specimens from the patients that have been treated with FAC inhibition and sort out their fibroblasts to identify the changes in phenotype.
It's great. Great
Thank you.
talk. Great work. Thank you.
Thank you very much. So now we come to our first virtual speaker. That will be Charlotte Leonie van Veldhuizen, and she's going to present a paper on artificial pancreas, bihormonal closed-loop glucose control versus current care after total pancreatectomy, outpatient randomized controlled crossover trial. So that's going to be it's a difficult title, but a very interesting story. Charlotte, I hope you can hear us. And I hope we can also see your talk.
Good morning, everyone. My name is Charlotte van Veldhuizen, and first of all, I would like to thank the APA for the opportunity to present the results of the APA5+ study to you today. The APA5+ study is a crossover randomized controlled trial in which we have studied the safety and efficacy of the Biomono artificial pancreas in patients after a total pancreatectomy. And I would like to declare that there are no conflicts of interest. A total pancreatectomy is an increasingly performed, however rare procedure in selected patients with IPMN, pancreatic cancer, and therapy refractory chronic pancreatitis. All these patients will develop insulin-dependent diabetes due to the complete absence of both alpha and beta cells. It is sometimes referred to as brittle diabetes, and due to the fact that these patients are constantly aware of the need to actively measure and regulate their glucose levels and fear hypoglycemia-related events, it is accompanied by a loss of quality of life. The current treatment includes insulin pen and pump therapy, which requires many procedures per day, and maintaining and managing adequate glucose levels with this current treatment remains challenging. Therefore, optimization of treatment of insulin-dependent diabetes mellitus after a total pancreatectomy is a clinically highly relevant goal. Recently, the first CE-marked Biomono artificial pancreas was developed by engineer Robin Koops and his Dutch company Inrede Diabetic. At a young age, he was diagnosed with insulin-dependent diabetes and started to work on an artificial pancreas with a self-learning algorithm in his garage. Throughout the years, this prototype has been improved, and he even received the National Icon Prize for this achievement. The artificial pancreas, as mentioned, is bihormonal and fully automated and contains a reactive glucose control algorithm, which is self-learning and is therefore able to adjust to a patient's specific need. The artificial pancreas, which you can see here on the right, is working closely together with the two sensors. These will measure the glucose concentration, and the transmitters attached to it will then integrate the information back into the artificial pancreas. Glucose levels that will then be regulated by the two infusion sets, glucagon and insulin, with a target of 5.5. Last year, this artificial pancreas was studied in type 1 diabetes patients and showed to be safe and provide superior outcomes compared to current diabetes therapy. And that brings us to our research question. Is the artificial pancreas in patients after a total pancreatectomy safe and efficient compared to current standard of diabetes care? Patients were able to be enrolled in our study if they were adult patients who underwent a total pancreatectomy and received diabetes treatment. We applied many exclusion criteria, of which the most important were that the total pancreatectomy was not performed within 3 months prior to the start of the study and in case of impaired awareness of hypoglycemia. For safety reasons, since it was the first in-man study, the study started with the feasibility phase in 2 patients. And after successful completion of this phase, the main study was able to start, in which patients after screening were randomized to start with either the artificial pancreas treatment or the current therapy, and then crossed over to the other arm. The current therapy at home was during 1 week and was seen as a control phase. Patients were able to use their own therapy and replaced a blinded CGM to register the glucose levels. The artificial pancreas started with a 5-day training phase, preceded by a training day of instruction in our institution. Patients were visited at home at day 1, 3, and 5, and we daily evaluated the insulin settings by our medical and technical team. Technical monitoring was provided 24/7, and it's important to note that this phase was excluded from our analysis since it was seen as a training phase for the patient to get used to the new treatment, but also to provide sufficient time for the self-learning algorithm for optimization. After the training phase, patients were able to continue the artificial pancreas treatment during 1 week, and only alarm-based technical monitoring was provided. In total, 12 patients were randomized in our study, and in both arms during the artificial pancreas phase, 1 patient, so in total 2 patients, dropped out because they could not give in to the new treatment. So in total, 10 patients were included in our analysis, of which the majority was male, with a median age of 62 years, HbA1c of 58, and a diabetes duration of 6 years. When we look at the primary endpoint of our study, time spent in range, this was significantly higher during the artificial pancreas phase, namely 78%, versus 57% of the time in the current therapy. When we look at the patients individually, we see marked in orange that the artificial pancreas provided in almost every single patient superior outcomes as compared to the current therapy. Secondary endpoints included time spent in hypo and hyperglycemia divided in level 1 and 2. And when we look at the hypoglycemia, this was significantly lower during the artificial pancreas treatment. Hyperglycemia level 1 was lower, however, not significant, and level 2 was significantly lower as compared to the current therapy. And the median glucose did not differ between the 2 groups. It is important to note that no serious adverse events were seen during our study, and patients only reported some skin irritations or they experienced some sensor difficulties. Therefore, we can conclude from this study that the Biomono artificial pancreas strongly improves glucose control and is safe in adult patients with insulin-dependent diabetes mellitus after a total pancreatectomy. We believe that larger randomized trials, including longer periods of treatment, are needed. And I would like to thank you for your attention, but also give a special thanks to the patients and family for participating in the study, and to Inreda Diabetic for the study material and technical support. If there are any questions, I will be more than happy to answer them. Thank you.
So the paper is open for discussion. I don't know whether we can actually see. Well, there you are, Charlotte. Great. So any papers, any questions from the floor? So that is a beautiful system, Charlotte. So did you encounter any disadvantages? Because the data is very convincing. You just showed even with these small numbers.
Yeah, so first of all, thank you for your nice words, and thank you for the question. We did experience some disadvantages of the Biomono artificial pancreas. We saw, especially in this group, as compared to the type 1 diabetes patients, that they were, in general, they were older patients, so they had to get used to the device taking over their normal rhythm during the day. So they were used to the fact that they were constantly aware of the need to actively measure, regulate blood glucose levels, and once of a sudden they had to let go of everything. So that's why 2 patients dropped out, because they actually thought that was too difficult for them. So that was something that we've learned, and I think in future studies we would definitely provide more support and guidance through that training period, especially to coach them and to guide them, into the new treatment.
Diane.
Hi, first of all, congratulations on really interesting and important work to try to advance the care of these patients, which can be quite difficult. Intuitively, it makes sense that bihormonal therapy would be better for these patients, but did you specifically prove that having insulin and glucagon was superior to insulin alone? So that's one question. And then secondly, are you building in quality of life measures and cost analyses? Because you could see how this could really take off and be broadly more applicable, but those are going to be societal issues that'll need to be measured. Thank you.
So thank you for your 2 questions. So first of all, I think that's an important question, because there are other artificial pancreas devices available solely using insulin. We believe that it's best to treat bihormonal. There's not much research and not a lot of evidence to it, but when you look at our numbers, it is extremely important that we see that there are actually no time spent in hypoglycemia, which especially in this group is very important. But we need to do further research to that. And when I come to your second question, that's an important one too. But since we only had a really short period of treatment, 1 week versus 1 week, it was very difficult to include assessment of quality of life. But we are actually working on a follow-up study with including longer periods of treatment and more patients, in which we've already discussed with a professor of psychology to include especially qualitative questionnaires regarding quality of life. But we believe that longer periods of treatment are needed to make a difference in that, because 1 week is very short to assess that.
Hi, I'm Maria Monberg from MD Anderson Cancer Center. Great talk. Quick question. When you're looking at the patient arms, and I guess for future studies too, those who have not received the artificial pancreas and are just doing, I guess, current standard of care and monitoring for their diabetes management, are you incorporating data from the newest Dexcom analytic devices? I'm wondering because, I have a lot of involvement with type 1 diabetics, and the newest Dexcoms, especially with all of the Bluetooth coordination, patients can check, every 5 minutes their blood glucose levels, and it's really made quite a difference for a lot of patients. So I'm wondering, with the artificial pancreas and the monitoring that the AI is doing, which I'm sure is fantastic, how that compares with patients who are currently on like the newest Dexcom for their own monitoring and their own management.
Yes. So that's a good question. We are actually currently talking to the company to involve the new Dexcom blood glucose manager. So that's something that we are thinking about. And in terms of the self-learning algorithm, which is crucial because basically what we see in our specific group of patients that they're so far are not able to eat specific kind of meals. They're not, some were not able to do physical activities for years already. So that also brings us to the family and social participation, which is actually quite low in this group because they constantly fear, they have a fear of risk of hypoglycemia related events. So we believe that the additional self-learning algorithm, which even probably is going to be even more improved during a longer period of treatment because it has more data to suggest to adjust basically. So yes, we believe that the self-learning algorithm is still an advantage when you compare it to the current diabetes care. I'm not sure if that answers your question, but maybe.
A little bit. I think, you know, I guess my hope would be that as like the Dexcom 6 comes out within the next calendar year and you guys work more on that partnership and kind of parse through what I'm sure will be a very large data set at some point, that we'll get to see some meaningful results there. Very cool work.
Great, great discussion. Thank you very much. I think we had better move on to the next talk, which is also a virtual talk. Developmental lineages and intratumoral heterogeneity of pancreatic neuroendocrine tumors at a single cell resolution. Coming to us from Boston, Jimmy Guo at Mass General.
Hi, everyone. My name is Jimmy Guo. I'm a graduate student based at the Broad Institute, and I'm going to present on some preliminary work we've done to characterize pancreatic neuroendocrine tumors at a single cell resolution. Well-differentiated pancreatic neuroendocrine tumors, or PANETs, are a rare and heterogeneous disease that comprises about 1 to 3% of all pancreatic neoplasms. They typically have lower proliferation indices and can be categorized as non-functional or functional as far as their clinical presentation goes. Functional PANETs are characterized by the manifestation of clinical symptoms as a result of excessive hormonal secretion. As a result of their rarity, PANETs are relatively understudied, but nonetheless, they can be considerably malignant. They often present as disseminated disease, and their incidence is also on the rise. Studies over the past few years have now performed genetic and transcriptomic analyses of PANETs to identify potentially novel molecular subtypes. These include those that are based on recurrent somatic mutations, proteotranscriptomic efforts, which have led to the identification of 4 expression-based subtypes, such as PDX1 high, alpha cell-like, stromal mesenchymal, and proliferative, as well as enhancer signatures that are able to stratify non-functional PNETs. However, what remains missing from the field is a high-resolution transcriptional examination of malignant cells and stromal cell types in the microenvironment. We therefore optimized and performed a single nucleus RNA-seq technique that is compatible with flash-frozen archival resection PANETs. Our current cohort consists of 6 specimens and is comprised of 4 untreated non-functional PANETs, 1 treated non-functional PANET, and a glucagonoma. With this data, we performed cell type annotations using a combination of strategies involving differentially expressed genes and multiple select marker genes, and identified high confidence cell types consistent with acinar, cancer-associated fibroblasts, endothelial, immune cells that we partition into lymphoid and myeloid, and neuroendocrine cells that are putative malignant cells. We then performed cell type quantification for each of these cell types across the patients. The vast majority of cells, as expected, were annotated as neuroendocrine, but we also noticed that many patients contained a relatively high proportion of endothelial cells. This is consistent with the notion that to serve their hormonal functions, islet cells are often surrounded by an endothelial capillary network. And indeed, islet cells often rely on endothelial cells for their extracellular matrix. Next, we sought to focus on neuroendocrine malignant cells in greater depth, and we therefore isolated this cell type for further analysis. Consistent with what has been noted in prior single-cell atlases of other tumor types, we noticed that tumor cells generally segregated by patient. Many constitutively active or aberrant signaling pathways also underlie many malignancies. So we wanted to map hallmark gene sets corresponding to K-Ras signaling, PI3K-mTOR, Wnt, and Notch signaling onto our data. This showed that these signatures generally localized to distinct pockets on the UMAP, although the segmentation of our data was only mild to moderate. What this also showed was that at baseline, RAS signaling, a pathway which heavily drives pancreatic ductal adenocarcinomas, was attenuated relative to the other signaling pathways shown here. A prior study had reported on the existence of 4 expression-based subtypes that have been known as PDX1 high, stromal mesenchymal, alpha cell-like, and proliferative. We examined these signatures in our own data set, and while we observed that some cells express these subtypes more strongly than others, they generally did not segregate our data very well. However, consistent with our expectations, the PNET007 specimen expressed the proliferative subtype the most strongly and also happened to be the highest grade tumor in our cohort, a grade 3. We therefore wanted to evaluate whether we could derive gene expression programs de novo using our collected data set. And unlike prior studies, we wanted to understand programs that were not only expressed across bulk tumors, but across cells. We performed consensus non-negative matrix factorization and found 7 programs that we determined to be statistically distributed across multiple patients, such that we were not identifying patient-specific programs with limited generalizability. We then performed gene set enrichment analysis and gene set overlaps and observed the presence of programs that corresponded with microRNA enrichment, a potential epithelial-like lineage plasticity as determined by markers such as CFTR and keratin 19, ribosomal activity, mesenchymal-like features such as collagen expression, which also correspond with the prior signature, a program that was enriched in TRIM proteins. The TRIM family is known to play crucial roles in hormone-driven cancers and can impact cell cycle progression, apoptosis, and chromatin remodeling. And we also found a proliferative subtype that was characterized by Ki67 expression and which seemed to line up with the prior proliferative subtype as well. And finally, a program which resembled endothelial-like differentiation with marker genes such as PCAM and von Willebrand factor. To limit the possibility that these programs were due to contamination from other cell types, we confirmed that these cells expressed hallmark neuroendocrine genes. And when we looked at these programs on a patient level, we observed intratumoral heterogeneity of these programs, as you can see here. So in summary, PANETs are an understudied disease in need of greater molecular characterization and treatment options. Although prior studies have made important improvements to our understanding of this disease, they were performed on the bulk level, which may result in gaps in our understanding regarding intratumoral heterogeneity and potential interactions between different cell types. Here, so far, we have performed consensus NMF and identified 7 new programs, including those corresponding to TRIM-enriched genes and alternative lineages within the pancreas that are suggestive of plasticity. Moving forward, we want to expand the size of our cohort, perform genetic and mutational analyses, and also elucidate some of the relationships among our identified programs and cell types in space. So I want to acknowledge many people who have made this project possible, including William Huang at the Mass General Hospital, Karina Shao, Christina Ferroni, and Berkham Deshpande, Andrew Aguirre at the Dana-Farber Cancer Institute, our collaborators at the Broad Institute, as well as the Koch Institute of MIT, including Zachary Ely, who's been performing a lot of the computational analyses. Thank you so much for listening, and I look forward to answering questions during the Q&A session.
This paper is open for discussion. Jimmy, it's a great start. It's very interesting, and you know, you said that you're going to expand the cohort to more patients. How many more patients are you planning to enroll, and I guess what other endpoints are you planning to look at to match your transcriptomic profiles with I guess the clinical progression of the disease?
Yeah, it's a really good question. So we're probably hoping to recruit at least 5 more patients, at least for the single cell component of this analysis. But we're hoping to take some things that appear to be generalizable across many of the limited number of patients in our cohort and try to perform some validations, at least on IHC, through a larger clinical cohort, which we have at the hospital. So that larger cohort would be comprised of around 300 patients, and we have some clinical annotations for those. So hoping to see what associations pan out in that setting.
Great. Another question.
You think these neuroendocrine tumors are acquiring vascular mimicry phenotype? They're taking some endothelial markers, for example.
Yeah, that's a really good.
Like endothelial cells.
Yeah, it's a really good question. It's actually something that we had thought about as well when we saw that particular endothelial-like program emerge. I think what you're alluding to is that in certain cancers, it's known that these cancer cells can potentially mimic vasculature and often form these routes for themselves to disseminate and leave the primary site. And I think it's consistent with what we know about the disease. Approximately 70% of PANITs will present as metastatic disease, and it's known that the blood vessels are intimately involved with these cells at baseline, given that they serve some hormonal functions. So I wouldn't be surprised, but I think it's something that we'd probably want to confirm through some spatial analyses and to observe some potential morphological or phenotypic changes in that setting.
Thank you.
Jimmy, thanks a lot. We need to move on to our next talk, but I just like to remind everybody that there's the possibility to put questions in the chat, and they can be answered within the next 3 months. So if you have any questions to any of the virtual presentations, please go ahead and use the chat function in the app. So the next talk is going to be given by Kathleen L. Del Giorno from Vanderbilt University. It's on single-cell transcriptomic reveals a conserved metaplasia program in pancreatic injury.
Hi, I'm Kathy Del Giorno. I'm a newish assistant professor at Vanderbilt University, and I'd like to thank the organizers for giving me the opportunity to share our recently published work on metaplasia with you today. Metaplasia is a reaction in the epithelium and many GI organs to chronic injury. It is the substitution of one cell type for another, and it has often been described as a single-step developmental reversion. Common examples include Barrett's esophagus, where the lining of the esophagus becomes intestine-like in response to injury, or spasmolytic polypeptide expressing metaplasia, or SPEM, in the stomach. In the pancreas, Asner cells undergo acidoductal metaplasia in response to injury or oncogenic mutation, and this is an early event in both pancreatitis and pancreatic tumorigenesis. So in response to injury, these Asner cells undergo ADM to form ductal lesions, which are resolved if the injury heals. But if there's an oncogenic mutation, such as in K-Ras, these lesions will instead progress to pre-tumor and eventually cancer. We've previously shown that these metaplastic ducts are not homogeneous and instead incorporate differentiated secretory cells such as Tuff cells. Tuff cells are solitary chemosensory cells. They are secretory cells that express both inflammatory and neuronal effectors, and they can be identified by their very specific structural features of tall, blunt microvilli and deep actin rootlets, which are shown here in this electron micrograph. Last year, we used lineage tracing, where we labeled Asner cells with YFP and then induced injury, to show that about 99% of pancreatitis-induced Tuff cells are derived from Asner cells. So this led us to ask what other cell types arise during ADM. To answer this question, we again used lineage tracing, where we labeled Asner cells with YFP. We then used cerulean to induce pancreatitis. We isolated YFP positive cells, YFP positive cells by FACS, and then performed single cell RNA sequencing. And as you can see here, we identified 4 different major cell types, including Asner cells, mucin ductal cells, Tuff cells, but also this population of enteroendocrine cells. We undertook about 4 different computational biology approaches to look at the relatedness of these populations, and they were all consistent in that Asner cells first move through this mucin ductal intermediate before forming either enteroendocrine cells or Tuff cells, which are distinct lineages but share a common progenitor population. Consistent with this, when we labeled single Asner cells with a Brainbow reporter and then induced injury, we saw that a single Asner cell can generate an entire metaplastic duct, and that these ducts contain both Tuff cells and enteroendocrine cells. from the expansion of a single acinar cell. We also looked at epithelial heterogeneity using electron microscopy. What you're looking at now is a video of scanning electron microscopy performed on 250 serial sections within a single metaplastic duct. We then projected these cells in 3D. Here is a tough cell. This is an enteroendocrine cell with delta cell morphology. And they are adjacent to an acinar cell here in orange, which is binuclear, and a mucus-producing cell. And so we're now using this data to look at how these different cell types interact and whether or not there are patterns in their formation within these ductal structures. When we took a closer look at our mucin ductal population, we identified expression of genes that are often described in gastric tumorigenesis or gastric metaplasia, SPEM. To look into this idea further, we examined this previously published data set of normal stomach and metaplasia in the stomach. We generated a differentially expressed gene list between chief cells and metaplasia, and then we overlaid this data set onto ours and found enrichment in the mucin ductal population. And this was confirmed with immunofluorescence and immunohistochemistry. So what this shows is that different GI organs are undergoing similar transcriptomic programs when they undergo metaplasia. When we took a closer look at our enteroendocrine cell population, we were surprised to find quite a bit of heterogeneity in terms of hormone expression and the formation of differentiated subtypes. This was also confirmed by immunohistochemistry, where we see serotonin expression or enterochromaffin cell formation and somatostatin expression or delta cell formation. And there are other subtypes here that we're examining as well. We next asked how injury-induced metaplasia compares to oncogene or K-Ras-induced metaplasia by comparing our data set to a recently published data set, which used a similar lineage tracing strategy. And you can see that most of the cell types we've identified are present here as well, including tough cells and enteroendocrine cells. But mutant K-Ras expression also results in the formation of a pit-like cell population, which expresses MUC5AC, which is shown here with immunohistochemistry. We next asked if these metaplastic cells themselves are susceptible to transformation by oncogenic K-Ras. To do this, we used a ductal cell-specific Cree, whereas when you activate mutant K-Ras, there's no discernible phenotype in the pancreas. However, if you first treat with cerulean to induce metaplasia, which expresses H and F1 beta, and then activate mutant K-Ras, you get pannin, and you see K-Ras-specific changes such as expression of MUC5AC. Similarly, when you do the same strategy, but with a Cree which recombines in tough cells or tough cell progenitors, such as POW2F3, you can see that expression of K-Ras alone, again, results in no discernible phenotype due to the lack of POW2F3 expression in the normal pancreas. But if we induce POW2F3 expression and tough cell formation with cerulean, and then activate K-Ras, again, we see the formation of pannin and K-Ras-specific changes such as expression of MUC5AC. We do see these cell types in human pancreatitis, as shown here. And this is a previously published data set of single nucleus sequencing in the pancreas from normal and chronic pancreatitis patients. We see tough cell formation. We see enteroendocrine cell formation by immunofluorescence. And you can see that this SPEM signature is enriched in the mucin ductal population here as well. So what I've shown you is that in response to injury, acinar cells undergo metaplasia, but they actually form a very heterogeneous population of cell types. They move through this mucin ductal intermediate and then form both tough cells or enteroendocrine cells, which exist as distinct lineages. So now what we're doing in the lab is we're looking at the function of these different secretory cell types in pancreatitis and pancreatic tumorigenesis. This data set has also allowed us to identify a number of regulons which are predicted to control the formation of these different lineages. So with that, I'd like to thank my laboratory, in particular Leah Kaplan, who is here. She's an outstanding graduate student, and she'll be presenting a talk on Friday morning. The first author of this study, Dr. Zibo Ma, who did all the bioinformatics analyses, and Dr. Nikki Lytle, who handled all of these single cell sequencing samples and will be presenting a talk here on Friday afternoon. Sammy Weiser-Novak, who did the electron microscopy, and then all of my Vanderbilt colleagues and our funding sources. And with that, I'll take any questions.
Jill Smith, Georgetown. I know that you used the cerulean model to induce your injury and inflammation. Do you know if using maybe a different model like a pancreatic duct ligation or something else to induce pancreatic injury would have the same effect? And do you know if your cerulean-induced model also, since it's activating the CCK receptor signaling pathway, is that part of what's going on here as far as the ADM production?
So to answer your first question, we did also look at duct ligation. And so for the cerulean protocol, we look at either 2 or 4 weeks of treatment. So we did that with the duct ligation. It's a much more serious injury. So we saw a lot more cell death and then we saw steatosis. In the adjacent acinar tissue that wasn't completely destroyed, we saw the same changes. We saw the same cell types, but they're much more highly enriched in the cerulean model because we can cause these changes fairly evenly across the pancreas. So it's easier to study, but we see the same effects in response to injury. And I don't believe it's a CCK specific effect because we see it in the duct ligation model. And we've seen these changes in a salmonella-induced pancreatitis model as well. So it appears to be kind of a general response for acinar cells to mitigate injury.
Great. Thank you.
Hi, Kyle McAndrews, University of Nebraska Medical Center. So I was curious, have you looked at any interaction between the pancreatic tough cells and the innate lymphoid type 2 cells?
No, we're getting there. We have now knocked out tough cells with pancreatitis and we see enhanced injury. And we've done the same thing with knocking out IL-25 and it looks like there's a delayed clearance of the immune infiltrate. But at this time, I'm not sure if it's a type 2 response. And when we looked at it with K-Ras expression, we didn't see anything that was type 2 specific.
Okay, it'd be really interesting to see if there's any interaction between the tough cells and the immune cells like there is.
Oh yeah,
IL-6
absolutely,
tough cell
absolutely. So now we're moving into using this injury protocol with our tough cell knockout or enteroendocrine cell knockouts and seeing how that changes the immune cell infiltrate.
Awesome, thank you so much.
Thank you.
Hey, Laura Wood from Hopkins. Great talk. Can you talk a little bit about any evidence for these cell types in human pancreatic precancers? And if you've been able to look at that in human samples?
So we have, and we find the same patterns where all of these cell types tend to be more enriched in metaplasia and then they decrease with progression in pan and then to cancer. They're generally found in the distal lesions that are non-invasive. And we find quite a few of these different cell types in normal pancreata or supposedly normal pancreata. So the metaplasia seems to occur maybe just as a general response to injury. Leah Kaplan will be presenting her work quantifying the different enteroendocrine cell subtypes in human samples, but that is also ongoing.
Awesome. When is her talk? So
It's on
everybody can
Friday
go?
morning. It's
Awesome.
on Friday
Everybody
morning.
should go.
Richard Waldron from Cedars-Sinai. Hi, Kathleen. Very nice talk.
Thank you.
You put a lot of emphasis on this heterogeneity of the epithelial cells in the ADM process and tough cells, enteroendocrine cells. But as you call them mucinous intermediates and so forth, I have this wild theory that like the mucinous intermediates that participate in pannins are really there to make lots of mucin, and then the mucin gets secreted and food for the tumor. That's just my favorite theory. But I wonder just if I didn't miss it, what is the relative proportion of these peculiar different cell types in the tumor when it's evolving? And do they progress to some other intermediates, or do they become tumorigenic, tumor cells, or, what is their role in the process?
So that's a really good
And
question.
the relative proportion with, per se tumor cells versus tough cells and so forth.
I can answer it quick. So
Yeah,
these metaplastic populations, the differentiated secretory cells and the mucus cells, they are generally lost with progression. You still have a lot of mucus producing cells in pannin, but what we see is that a subpopulation within that population that doesn't have as many SPEM markers expresses a lot of tumor markers, even in the injury model. So we think that that's so we think that's the population that's really expanding throughout disease progression, and it's one that might indicate relative risk. for progression.
By the way,
Great talk.
I also see the gastric, okay.
Yeah, sorry, we're super late. All right, last talk from Kiyoshi Seiki from Columbia University. Inactivation of Notch4 suppresses pancreatic tumorigenesis in mice. Kiyoshi.
Hi, my name is Kiyoshi Saiki, and I'm postdoctoral research scientist at Gloria Su's lab, Columbia University. Inactivation of Notch4 attenuated pancreatic tumorigenesis in mice. Notch signaling has been implicated in number of malignancies, including pancreatic cancer. Notch signaling pathway prevents cells from terminal differentiation and maintain the pools of undifferentiated stem cells. In mammals, Notch1 to Notch4 have been identified. The putative oncogenic role of Notch signaling pathway in pancreatic tumorigenesis have been investigated using mice model. Studies to the Notch signaling pathway have focused on Notch1 and Notch2. The role of Notch4 in cancer is largely unknown. So in this study, we investigate how Notch4 is involved in pancreatic tumorigenesis. To evaluate it in vivo, we use the previously published PDAC mice model, which have a P16 frogs, K-Ras and P48 Cure PKC mice, and conventional homozygous Notch4 deficient mice model were bred to PKC mice and generate Notch4 loss PKC mice. We evaluated the survival curve between them. The Notch4 loss PKC mice have better survival than PKC mice. And also we evaluated the histology at the time point of 2 months and 5 months. At 2 months, the proportion of pine lesion at Notch4 loss PKC mice was significantly lower than that of the PKC mice. And at 5 months, the proportion of PDAC lesion in Notch4 loss PKC mice was significantly lower than that of the PKC mice. This figure indicates that inactivation of Notch4 delayed the development of pine and PDAC and have a preferable outcome. We also evaluated the expression area by Notch4 expression area by immunohistochemistry. We recognize that Notch4 was highly expressed in ADM and pine lesion. We also evaluated the Notch4 expression pattern by immunofluorescence. This above figure means Notch4 and amylase double staining, and below figure means Notch4 and CK19 double staining. These figures indicate that Notch4 was highly upregulated in ADM and pine. So we hypothesized that Notch4 expression induces acidoductal reprogramming. So we focus on the role of Notch4 on ADM induction. Based on this hypothesis, we employed the cellular treatment pancreatitis model. We performed cellular treatment among KC mice and Notch4 loss KC mice and evaluated the ADM and pine lesion at the time point of day 2, day 7, and day 21. This IHC showed that the proportion of amylase positive area in Notch4 loss KC mice was significantly higher than that of the KC mice. And also the proportion of CK19 positive area in the Notch4 loss KC mice was significantly lower than that of the KC mice. This figure indicates that loss of Notch4 reduced the ADM pine formation induced by oncogenic K-Ras and cellular treatment. To further investigate the role of Notch4 on ADM induction, we used the ex vivo 3D culture model. We evaluated the number of ADM events between K-Ras group and Notch4 loss K-Ras group. With adenocure, the number of ADM events in Notch4 loss KC group was significantly lower than that of the Casey mice, which figure confirmed that Notch4 is an important contributor to K-Ras mediated ADM programming. We also performed RNA sequence analysis between PKC PDAC mice cell lines and also Notch4 loss PKC PDAC Notch4 loss PDAC mice cell lines. RNA-seq data indicate that PCSK5 was one of the most significantly differentially expressed gene. And also by qPCR, we recognize that PCSK5 expression in the Notch4 loss PKC mice PDAC cell line was significantly downregulated compared to that of PKC mice. This IHC showed that the expression level of PCSK5 in pain and PDAC lesion in Notch4 loss PKC mice was downregulated compared to that of PKC mice. And human protein atlas showed that PCSK5 low expression patients have a better prognosis compared to that of high expression one. This figure indicates that Notch4 loss resulted in downregulation of PCSK5 in pancreatic tumorigenesis and progression, decreased expression of PCSK5 correlated with good prognosis in patients. As for PCSK5, it is a member of the substrate-like protein converters, PC family. PCs are involved in numerous malignancies such as skin and head and neck and colon and other cancers, but not yet investigated about pancreatic cancer. KC inhibitor has been successfully used in pilot studies for other cancers. So we use this PC inhibitor for the mice PDAC cell lines and evaluated the proliferation. This is still a preliminary data, but this figure indicates that PC inhibitor suppressed the proliferation in mice PDAC cell lines. So we thought that PC inhibitor could be a novel therapeutic strategy in the future. This is the summary. Notch4 as an oncogene pancreatic tumorigenesis, and PCSK5 may be a novel downstream mediator in the Notch4 deficient pancreatic tumorigenesis. Inhibition of Notch4 PCs could be a novel therapeutic strategy in the future. Thank you.
Great, thank you very much. See anyone at the microphones? I have one question. How much does the phenotype of your Notch4 knockdown or inhibition overlap with the more canonical notches 1 and 2? So is this PC SK5 also downstream of notch 1 and 2?
Usually the PCSK5 would not overlap other kind of notch signaling, so which is specific for Notch4. That's why we focus on the PCSK5.
I agree. Wonderful. Okay. Great talk. Thank you very much. Thank you everyone for coming to this session. Really enjoyed it. And let's go get some coffee. The next one starts at 10:15 in here. Thank you.
Thank you.
Thanks.